Hi, everyone.
Good evening.
Hello.
Sorry, just putting my volume up if anyone said something to me. Other than,
I said hello.
Good evening, everybody.
Good evening.
hi, Diego.
Renee, how are you? I feel like I haven't seen you in an age.
I know, it's been a while. I've been great, thank you. How about you?
Good, busy, very busy. My final child has committed to college, so he's going to go to University of Vermont in the fall. So
Nice.
Congratulations.
thank you. So 3 for 3. Woohoo!
We took a big step with our youngest in college. She was home for spring break. She goes to Hunter in New York City. And, she'll be back for the summer in like 3 weeks, 4 weeks. And, we'd have to go and move her out of the dorm, but she's got a grandmother on Long Island. So we're like, why don't you just take the car and park the car at grandma's and move yourself out of the dorm? And she thought that was a great idea. And so do we. So we're now a 1-car household, but we don't have to haul our cookies down to New York City and move someone out of a dorm. So
That's a win-win right there.
That's a
contrast that with Willie, who, really takes care of his kids compared to me.
Yeah, 12-hour trip there and back, University of New Haven.
Wow.
My daughter does not want to drive in Connecticut. I can see why.
Yeah. Yeah. We're starting that. We have to do pickups in May for the other 2. So we're going to start that little road trips.
Yeah.
So.
I just want to do drop-offs. I don't really want to do pickups.
Oh boy.
People are coming in slow, Diego. I'll let you know when we have critical mass. I mean, I feel like right now the only person we've got is Dr. Landgraf and you, and the rest of our esteemed staff, of course.
Oh, wow. Yeah.
Well, I think when Chad and I are in the same room, it's like 50 people, right? We'll talk up a storm if we have to.
That's exactly right. We'll just talk for fun.
Absolutely. Make fun of each other, even that we'll be able to do.
Exactly. It's good.
And I see Katie there, finally doing some work. I see, that's good.
Always a comedian.
Should we tell the group about our idea for promoting colorectal cancer screening in age?
Oh, gee.
You have a new idea?
No, the same one we talked about at PR Clinical yesterday.
Oh.
Which was renting that, that inflatable colon that you see brought around and having Chad dress up in a brown jumpsuit and run in and out of it.
He said he would. I heard him.
He said he would. That's right.
He said he would do it immediately, as I recall.
Exactly.
As long as I could get some yellow Nerf balls and stick it to me like, corn.
It's just the metoprolol capsule that didn't digest. Come on, Chad, you know that. It's the capsule that didn't digest.
I have to move past the cardiologist part of it. Yeah, I like the GI side.
Yeah.
Living vicariously.
Oh boy. I think colorectal cancer screening would go up though with that.
Absolutely.
I think
People
it's
may-
a really good shot.
Exactly. It's a lot more exciting than, hey, look at this fit card.
Let me know when you want to play Truth or Dare because it sounds like this will be fun.
Not much I won't do.
There are 5 more folks that who said they're coming that we're waiting on. So if you don't mind, Diego, if we could just give them a couple minutes.
Yeah, no, I'm good.
I mean, the conversation is so sparkling already.
Absolutely. Well, Steve wanted a joke last time and I kind of choked and I didn't have one for last time. So I mean, I might as well tell it now. I've been preparing for this one for a while. So this son comes in home and he says to the dad, "Hey dad, I think when I grow up, I'm going to be a politician." And the dad says, "Are you insane? Are you out of your mind? Are you a moron? Forget it, Dad. It sounds like there's too many requirements."
As a politician, I resemble that remark.
I was about to say.
Not local. We're talking federal. Come on.
He really has been working on that for quite a while. And rehearsing.
Well, the PowerPoint that I showed you the other day for it, Katie, in the office, right? That would really help that.
What was that? I missed that.
PowerPoint that I put up in order to explain the joke was pretty good.
Oh, yeah, yeah.
Well, anyway, while we wait a little bit, whoever's here on the call right now, if you would like to put your name in the chat for attendance, that would be helpful. And also, if you're on a phone or a device that you're not able to write your name, if you want to speak up and say your name, or if you'd like to email Renee separately, let us know you were here, that would be helpful just from an attendance standpoint. And I'll repeat this in a minute anyways.
Thank you, Diego. Thank you.
Yeah.
George, you don't count.
There's the brown jumpsuit.
You're not going to join him on that little jump, are you, George?
He's the understudy. That's even worse.
Oh,
George, was the plan still to have Dr. Wallace present with you?
Yes, he did confirm this afternoon. So, well, if he doesn't show, if something delays him, I can certainly start without him, but he was planning to come. Let me try him actually.
The only other like welcome and introduction item that I had, Diego, was as I mentioned to you, we were hoping that we'd have new representatives to this committee who'd be joining us from the Lourdes Health System in Binghamton, which recently became part of AHP. Haven't seen them pop in yet, and I guess that when they do, we can take a pause and introduce them in between presentations, if that's okay.
yeah, absolutely. If you just let me know when that happens. I'll try to keep an eye out for them as well.
Okay. 6:07.
Should we just go ahead and get started?
Sure.
Okay. Welcome everyone to the second PCP Advisory Committee meeting for 2022. And we've got a little packed agenda today. Again, as I mentioned before, if you're just joining us, please put your name in the chat. If you're on a phone or a device that you can't type your name, please send an email to Renee or speak up that you're on the call for attendance purposes. We're going to start out today with the Project Teach, and Dr. Nasser, if you'd like to take over.
Okay, thank you very much. Yes, so I wanted to spend a few minutes introducing Project Teach, which is a initiative that started a while ago. Actually, Dr. Jim Wallace was going to join us because he actually is one of the founding psychiatrists for this project, which started as a consultation support program for pediatricians. As of January of this year, this program has expanded to include maternal child health. So right now, in addition to having consultations from pediatricians and family docs to discuss and present kind of difficult challenges with their pediatric patients, now also we have the same format, the same model for perinatal consultations. So if I can share my screen for a second. Apologies, just 1 second here. Okay. Okay, so Project Teach has a website, and I'm going to show you just a few pages from that website in a minute. But also to say that we have expanded to include OBGYN providers and family docs regarding maternal mental health concerns. There's a team of psychiatrists and psychiatric specialists across New York State. Here in Rochester, this is our team. What happens, just similarly to the Project Teach, for those of you who have used that in the past, every day of the week, Monday through Friday, from 9 to 5, if you call, you're going to have access to a psychiatrist. Friday is the designated day of the week where Rochester team provides that consultation for the whole state of New York. But every day of the week, you're going to have someone else. And we all meet on a regular basis to compare notes, to kind of discuss difficult challenges. So there is really very little variation in terms of the kind of service that you get on any day of the week. This is the child adolescent psychiatry team here, and there is an administrative team also that supports this program. The services provider, so what to expect from a provider perspective, if you call the consultation line for maternal child health, you will have the option of having a psychiatrist call you back within 30 minutes of that call. A lot of times what happens is we call back and the primary care provider, the OBGYN provider, prefers to schedule a time later during that day. So we call always within that 30 minutes, and sometimes we kind of agree on a time to call back during that day. The phone call, basically, we discuss a case with the provider, listen to the concerns, and provide feedback around medication management, around next steps in care for depression, anxiety, bipolar, safety of medications, whether it's during, before pregnancy, anticipated pregnancy, during, or after pregnancy, including breastfeeding questions. Also, our team of the administrative team really are, most of them are mental health therapists themselves, and they will assist the providers calling to make a linkage and referral to specialty care in the area where they're calling from. So we have compiled a large list of resources, and they can help refer your patient to those resources. We also are preparing a significant number of educational material, including webinars and intensive courses, and I'm going to share that information with you in a minute. This is the phone number to call. So if you Google Project Teach New York, you're going to get to that web page, and all this information will be there, but that's the number to call. Like I said, referrals and linkages and training. And if I can have a few minutes more here to share the website, because that will give us much better information on what you can expect to see over there. Is Jim with us, by the way? Okay, so this is the website for Project Teach. And if I go to, from that website, if I go to maternal mental health, this is the section that you will get to. And you can choose to click on consultation, which also gives you the option not only to call and discuss a case live, which is our preferred method. We want to have a conversation with the provider, but sometimes on a busy day, you may want to send an email question. And the email question will ask you very brief information about who you are, where you are calling from, and then your question, and you can submit that, and we can respond to that email also on that same day. Linkage and referrals is here, and then there's a list of resources, including webinars that you can access online, as well as, excuse me, if you click on education, you will find I'm looking at the upcoming webinars that you will have. Give me 1 second more.
And George, while you're doing that, I'll just make the comment to the folks that the Project Teach flyer was included with the agenda that was emailed to folks yesterday. I'm sure a lot of this information, the website URL is probably in there, right, George?
Thank you, Renee. Yes, the flyer was emailed, and I believe that this information that I'm sharing here was also included or will be included in the AHP newsletter. So there is, and we will continue to include in that newsletter upcoming trainings and webinars. All the trainings are free, and all the trainings have CME credit attached with them. So free CME, and hopefully you will find them helpful. So there is, for example, a webinar on May 9th around mental health matters for 2 generations, impact on perinatal mood and anxiety disorder. There is another one on May 16th. This is one that's a little bit more involved. It's from 4 to 7. That's one of our intensive training on May 16th. And it's followed by 3 sessions on May 23rd, June 6th, and June 20th, kind of like breakout sessions, if you want, as a follow-up to this webinar. And the whole series, those 6 hours carry 6 CME credits attached with them. So I want to stop here and see if there are any questions from this one.
Okay, I mean, I think that was very informative. I think, again, if we have the phone number right in front of us, it'd be helpful to have that in a flyer and maybe in a following communication to so everyone has that in front of them. And always free CME credit, always an important piece of our education. So thank you very much, Dr. Nasra. Renee, I see that Sanjeev Patel, I think, joined us. I don't know if you'd like to introduce him.
Yes, thank you. Welcome, Dr. Patel. Dr. Patel is a family medicine provider who joins us from the Lourdes Vestal Family Practice. And we're so pleased to welcome him and his Lourdes colleagues to AHP, and him in particular to the Adult PCP Advisory Committee. Dr. Patel will also be representing Lourdes on the Pediatric PCP Advisory Committee. So he's doing double duty on AHP Advisory Committee. So welcome, Dr. Patel.
Thank you very much. I'm glad to be a part of this, and I appreciate the opportunity.
Well, welcome aboard. Our next part will go to you, Renee, on our 2021 quality incentives.
Great, thank you so much. I'm going to share my screen. I have a pretty brief presentation to go over with you. I wanted to make you aware of a payment that's going to be sliding into your account tomorrow, since we pay everyone electronically. And this is the 2021 Quality Performance Incentive. So a lot of what I'm covering should be pretty familiar to you, because this has been the incentive plan for quite a few years now. Eligible for this incentive is all of our non-U of R employed primary care physicians. And now we've added APPs who've been enrolled in AHP. These are folks who are participating with all of our 2021 AHP contracts, and you had to be Arcadia implemented by a certain period. The period of time where we were reviewing quality in order to calculate this incentive is for the calendar year, January 1st through December 31st, 2021. The incentive program is based on on the Excelis commercial measures, commercial points and commercial benchmarks. It's for all patients, so it's population health based. Even though I'm saying that we're using those Excelis commercial measures, we aren't basing your performance just on your Excelis patients, just on your MVP patients. It's across the board, all of your active patients that are in your EMR. It's a provider-based incentive only. It's not a practice-based incentive. And there are 3 tiers of incentives. So for 2021, the incentive, like in years past, is based on the percentage of points earned. And these are, and your points, the points that you're eligible for based on your specialty. If you're internal medicine, you're only eligible to have incentive awarded on your adult measures. If you're family medicine, it's all of the measures. If you're pediatrics, it's just your peds measures. Although if you do, for example, as a pediatrician, have some patients who fall within adult measures and you have a certain, a threshold of them, I believe it's 5 patients in an adult measure, you do get credit for what your performance is there, but there's not many folks for whom that applies, and I won't complicate it any further. But we have 3 incentive levels, and just like 2020, for 2021, it's gold, silver, and bronze. To achieve gold, you have to have earned 75% or more of the points for which you're eligible. Silver is between 74% and 45%, and bronze is 44% or fewer points. Those are the incentive thresholds. I do just want to draw to your attention that these were adjusted dramatically to account for the pandemic, to account for patients just being unwilling to come in and obtain their preventive care. So I just want to show you what, sorry, got someone coming into the waiting room, what they were in 2019. To achieve gold, you had to earn 90% or more of the points for which you were eligible. So we lowered the bar a bit to account for the challenges that the pandemic presented. We lowered them in 2020, and we wanted to maintain that for 2021. And please pop any questions into the chat or go ahead and speak up. Now, what are the payouts? Well, for 2021, folks who have earned gold will earn $5,600 per providers. Physicians in the silver range, $4,650, and bronze is $1,700. Now, brand new for 2021, we're including APPs. So these are nurse practitioners and physician assistants who have a number of patients within denominators to qualify them. And we want, and this will be their first entry into our incentive program. So this is just going to be a base incentive, kind of an introductory value to welcome them to the incentive program. But we certainly anticipate that in the following years under the new PCP reward program, we're going to find ways to achieve some equity in these incentives between physicians and APPs in a way that works best for the network. But for right now, our first go at it, every APP who is eligible in the incentive plan earn $1,700 base amount. Just want to quickly show you, like I contrasted earlier plans with this year. In 2020, these amounts were $6,000, $5,000, and $3,000. So we widened the gap a little bit between silver and bronze. And we had to bring down the amount a little bit just based on the number of physicians and providers included in the incentive program. Has resulted in a little lower payouts overall, but not very much. In case you're curious, we had 96 physicians who fell within the gold range, 51 falling in silver, and 76 falling in bronze. And that frequency within those ranges has been pretty consistent over prior years. We didn't see a lot of movement there. So these are the dollars that are going to be coming into your accounts tomorrow, some people Monday. We, as a matter of course, send to your practice manager a check detail report that shows for a given practice which physicians earned which amount. And it'll also include a communication detailing our plan here and how what was the methodology for reaching these numbers. As always, any questions, please reach out to me or to my colleague Jana. So what does this mean, moving forward? What's next in terms of quality related payments? Well, 2021 gain sharing, which is subject to board approval, so I can't really say hard and fast that this is what it's going to be. But I know that what staff will be recommending and what the board is likely to approve is that we're going to follow prior year's methodology of gain sharing, in that we're going to carry over that 2021 quality incentive, which is what I just talked about, which is what you're getting paid on tomorrow and Monday. We're going to carry over that performance level for the quality component of gain sharing, which, as you'll remember, in past years, we paid a base amount in gain sharing. And then there was a per patient amount to recognize those providers that had larger panels versus those with smaller. And then there was a quality component. So I don't know that the quality component will be the same dollar amounts as what I just covered. So I mean to say, will the quality component of gain sharing, will the gold component be 5,600, the silver 4,650? I don't know. But if you earn gold in this payment, you will earn a gold quality component under 2021 gain sharing. Given, of course, that the board approves our recommendation and that we adhere to that methodology. I can't talk about quality without talking about what's coming for 2022. And you've heard us talk about this a lot. And this is our new PCP reward plan. And this is going to mean one payment that's going to blend funds from both gain sharing and our incentive pool. The dollars we're paying you right now for the 2021 performance, that quality incentive we're talking about now, that's going away. And that's what we pay out of what we call an incentive pool. No longer. We're going to have one payment. It's going to blend the dollars that we use, that's the incentive pool, and whatever we earn in gain sharing. And the incentive is going to be awarded in 3 performance domains. It's going to involve your performance to quality, your performance to cost savings, and your performance in citizenship. Can't talk about the new PCP reward planning without talking about the provider engagement report, which really helps illustrate how the reward plan works. And we're currently piloting the provider engagement report in Diego's practice, actually, and we're looking forward to rolling that out to additional practices soon. So any questions that you have about the current payment that we just talked about that you're getting paid on tomorrow, the 2021 quality incentive, please let me know. And as always, there'll be a lot more dialogue about what's coming in 2022 related to the new PCP reward plan. I know I just covered a lot, and I'm looking at my slides and not at your faces, so I can't tell if you all look gobsmacked or bamboozled. So please, whatever questions you have, let me know.
Thank you very much, Renee. Any further questions, please email Renee. Again, if anybody joined the call after these 2 presentations, please put your name in the chat or send an email to Renee letting us know that you've been in attendance today. The next up will be our Arcadia update by Willie Newidge, please.
Thanks, Diego. So I wanted to give a quick update on the Arcadia upgrade. Hopefully you can see my screen. So a quick reminder of what some of the things that version 6 will provide. They've added additional information and cleaned up the patient record window. And you can expect an HP created document that highlights the differences between version 5 and version 6, roughly about a week before the launch of the upgrade. And of course, it includes a new quality measure grids with updated measure definitions and this year's thresholds and points. It also improves the current data lag, where today it may take a week or more for your practice's data to be processed and represented in Arcadia. So they've updated their processing model so the data can be processed continuously without having an effect on system performance. And then there's the numerous tickets that most of us know about that are reportedly resolved with this new version. So the upgrade date was moved from May 2nd to June 20th. We moved it out because the new version just wasn't at the point where it was good enough. And we didn't want to move the date out 2 weeks, another 2 weeks. So I met with the implementation manager at Arcadia and we found a date that where they're confident that they can resolve the issues that are currently on the table that we found with our testing. For example, one of the issues we found was that a number of quality measures didn't show any qualifying patients. There were database issues that would have adversely affected our IT team and the great work they do. And lastly, there was an unplanned Arcadia SQL Server upgrade that also slowed us down. So what do we do in the meantime while we're waiting for V6? Knowing that the upgrade has slipped, 2 or 3 or 4 times. So Arcadia is in the process of updating the current version to mimic what we'll see in version 6. So the current version will include this year's quality grids along with the new thresholds and points. The only caveat is that they'll be using last year's definitions, but fortunately, there really isn't any major changes from last year's definitions to this year's. So we lucked out there. But unfortunately, we'll need to wait a bit longer for those upgrade dependent tickets to be resolved and for the data lag improvements that we expect with this new version. But know that we're working with Arcadia every day, multiple times a day to ensure that the new version is up to HP standards before you'll even see it. And that's all I had. Any questions?
Thank you, Willie. I know you put a lot of work into this, and I know there's been a lot of pitfalls over the last couple of years. So thank you for everything you do, because it's definitely something that we all look to help not only guide our patient care, but also help us perform better as we want to enter these new quality metrics. So thank you.
It's definitely a team effort.
Great. So on that note, Janet Darlington will update us on the VATIGA re-engagement program.
Okay, can everybody see that?
Yes.
Perfect. So I am just going to talk a bit about our VATIGA performance from 2021 and what that's going to look like going forward. Renee, I know you wanted to say some words about, why this is important to AHP and, the network. So I'll let you start there.
Great. Thank you, Jane. I appreciate that. So as folks who aren't currently involved with this program should be aware, our interest in this program, which is essentially a risk coding exercise. It's Excellus has partnered with us to offer this to our providers, because what it entails is providing a risk coding tool to our providers in order to more accurately code. It started with Medicare Advantage patients, but now includes commercial and Medicaid, to code them their chronic conditions more accurately, which in turn results in their acuity being properly reported to CMS, which in turn ensures that CMS is reimbursing Excellus appropriately for the acuity of those Medicare Advantage members. Why AHP has an interest in this, and that you should as well. I mean, not only on an individual basis are providers earning these super generous incentives, as you can see on the screen, but that our contract with Excellus for the Medicare Advantage population is a % of premium deal. So it's not just a medical expense budget. It entails the amount of premium that's collected on the population. The more premium that Excelis is earning, the more gain sharing that AHP is in a position to earn, and that's more gain sharing that you're in a position to earn. So there's benefits on the front end, which I'll let Jana get into more detail, and benefits on the back end on a more aggregate level is that percent of premium deal that we have with Excelis. So that's why we've got a dog in the fight. That's why we're bringing it to you, and also because we think it has great financial value for practices. So with that, I'll let Jana talk about our what has been achieved in the program over prior years and why we're interested in re-engaging and getting more providers involved.
So yeah, starting here, you can see that there is an abundance of money to be made on what, a visit that would have normally not made this much money. So with Excelis, that is a $175 incentive for each Vatica record that's signed. And then for providers that hit their target penetration rate, so they're signing over 65% of their records, there's an additional bonus, $50. So, you could stand to make $375 if you hit your bonus, do the visit, and you do that during an annual wellness visit. There are other payers that are included in Vatica as well. So it's not just Excelis, but that's what Excelis offers. Univera and MVP, it's $150 bonus incentive. And then in total, there are actually 6 payers that are included in Vatica. So if you are, you have populations that span outside of the Excelis, Univera, MVP, there is a chance that your payer is also included in this Vatica program. But why, that adds up. 2021, we saw over $1.5 million go out to our network in terms of base incentives, and then also that bonus. $995,000 of that was paid out on the Medicare line of business. Another $45,000 was paid out in Medicaid, which was just a pilot that did not span even a quarter of the year. And then commercial earned another $225,000 in base incentives. So, then there on top of that was this $285,000. So we had that amount paid out to an even smaller portion of providers, around 60 providers who hit their 65% penetration rate and earned additional dollars. So as you can see, there's significant value here in the upfront dollars that are brought into your practice. And, as Renee's saying, that also equates to how many more patients we're getting accurate coding for to report back to Excelis and CMS. So the entire effort this year around Vatica is going to be to reinvigorate it. We have, for that $1.5 million, we probably had 100 or so providers who were actively signing records in any significant quantity. So there's many more, over 200 who are actually enrolled in Vatica, trained in Vatica, but are not signing those records. So there's a lot of money that's being left on the table. So we really want to re-engage folks around this Vatica effort. And Vatica is helping us out with that. So they have made some significant upgrades to the tool. And so I just have a couple screenshots to show you guys what that really looks like. One of the concerns is always that it can be click heavy. The information is difficult to see because it's held in different sections. So they've actually improved this diagnosis coding screen, which is the first thing that you see when you go into the tool and view a patient. So now what you'll see is supporting documentation is right there in a concise manner. They've also added tests and labs that used to be held in an entirely different section of the tool. So now you can see that all along your supporting documentation. There's also this current medications that's been added to this, this part of the tool. So now you can see what's going on with that patient in tool view right in front of you without having to click through. To further make this a streamlined effort, they've actually condensed the MEET screen, which is that monitor, evaluate, assess, and treat screen. So this comes preloaded with any diagnoses that have any tests, assessments, or labs attached to them. If there is or is not any pertinent detailing associated with it, that is included. And so providers can actually just see this, review it, and say, yes, this is exactly what is going on. Those medications are pre-filled in. So, you know, they've really taken that feedback to heart and said, okay, how can we make this easier for providers to get through this? And then last, that summary that you get. After you fill in that diagnosis, you review that, you go through the meet screen, what you get, this PDF version of the summary that you've created is much more streamlined, a lot easier for you to view in its entirety. They've also made just some changing to the wording so that that's more easily incorporated back into your EMRs and things like that. So, you know, prior to these upgrades, everybody's worried about how long this is going to take. Right at the beginning of this, there was a time, it said 5 to 10 minutes to sign each Vatica record. Now, 10 minutes was for a patient who had multiple complex conditions, and there was a lot of material to be reviewed, so it could take longer. And those numbers also account for providers who are just starting out in Vatica and getting used to how to navigate the tool. They've actually found, even prior to this update, that the more records you sign, once you kind of hit that 30 record threshold, that time drops down significantly to under 5 minutes per record. So what they're hoping to see is that with these new upgrades, it's even less time that providers are spending doing these records. So really what it boils down to is the more records you do, the more comfortable you get with the tool, the more incentive you earn, and the better our reporting and coding is when it's going back. So, you know, we really want to engage providers who are, you know, participating, but feel like they could be doing more in Vatica. We want to find different ways to improve that performance. And then also those providers who, you know, have heard about Vatica in the past, but weren't, you know, sold on it. We want to have those conversations again to see if these improvements with the tool or if things have changed at the practice would make this more viable. So with that, I will stop sharing my screen just so I can see you guys.
Thank you very much, Jana. I'd like to speak to this as well. Having done Vatica for the past 4 to 5 years, they really have, as you stated, Jana, really made a dramatic improvement in their website and the ability to kind of go through that screen faster and becoming more comfortable with it. The other part for us clinicians in terms of Vatica, sometimes they do find a diagnosis in an x-ray that was 10 years ago or a consult note that was done 8 years ago, which you didn't pick up on or got scanned in the EMR, and it's actually helpful in patient care. And I would say that, you know, once or twice a year that happens. So they do find things that become clinically relevant for that patient as well. And so I think it's a very important tool from the patient perspective as well. In addition to the annual wellness visit, some patients can be their note can be completed from a 6-month checkup or just a regular office visit in some cases. So it doesn't even involve strictly only the annual wellness visit. So you can really get to these charts and get to your 60% in a very likely manner in 1 year. So I would speak to Vatica. I think it's been very helpful. It's very easy to navigate currently. I'm happy to have a conversation with any clinician who wants to get engaged in it or has questions about it or problems with it, because I feel very comfortable with this tool. So please feel free to reach out to me or ask Renee for my email address. Happy to discuss it with anyone.
Thank you for that.
Absolutely. Any questions for Jana? See none. Renee, it looks like we might have come to the end of our agenda pretty fast.
I know, we're super efficient. What can I say? Do you guys want us to come up with more stuff to talk about, or should we?
I think the 18 minutes of our lives back before 7 is a better choice.
Okay. Well, Dr. Connors just joined us. I'm sorry, Charlene, you're coming in at the end, but we're grateful for you joining us. Thank you. Dr. Connors got caught up with a patient and joining us late. But thank you all for coming tonight. We appreciate it. Any questions you have, follow up that you need, please feel free to email myself or Jana. And our next meeting is, I just closed the agenda. Is anyone?
June 30th at 6 p.m. will be our next meeting.
Okay.
And hearing nothing else, everyone have a wonderful Thursday and a happy weekend.
Take
Good
care.
night,
everybody.
everyone.
Take
Bye-bye.
care.
Bye.
Bye.
Bye-bye.